All right, let's dive in. Today, we're going to break down one of the world's most famous and, let's be honest, most debated public institutions, the UK's health system. We're going to unpack how it's all put together, follow the money that keeps it running, and take a hard look at the massive challenges it's facing right now. Everything, and I mean everything, starts with this single idea. This principle, laid down all the way back in 1948, is the very foundation of the National Health Service, or the NHS. It's the promise that has shaped healthcare for generations of people across the UK. So to really get our heads around how this all works, we're going to follow the money. We'll track it from the moment it's collected as taxes all the way to how it's spent on patient care. We'll start with that founding vision, then get into the funding and budget, see how care is organized differently across the UK, and finally wrap up by looking at how well it's doing and what the future holds.
Okay, first up, the principles. To understand the NHS, you really have to transport yourself back to the end of the Second World War. This was a time of huge social upheaval, with a powerful collective drive to build a better and much fairer society.
So the system was born in 1948 as one single unified service. But, and this is a critical point, it's not a single system anymore. 1999 was a massive turning point. That's when devolution handed over health powers, effectively creating four distinct parallel health systems. And that process of change is still going on, with England's 2022 reforms pushing for even more integration at a local level.
Right, so how do you pay for a system this comprehensive? The answer to that question really gets to the core of what makes it so unique. You know, a lot of systems around the world rely on things like social security payments or mandatory private insurance. The NHS is different. It's treated as a fundamental public good, paid for collectively by everyone through their taxes. So let's take a quick look at where that tax money actually comes from. What's super interesting here is the breakdown. You see those three biggest slices of the pie? Income tax, national insurance, and VAT. Together, they make up about 2/3 of all the money the government brings in. This is the financial engine not just for the NHS, but for all public services. And this number, well, it's pretty staggering. Around 80% of all spending on health in the UK comes from the public purse, from those taxes we just saw. That other 20%? That's made up of things like private medical insurance and people paying directly for services the NHS doesn't cover. And this is the key takeaway, that tax-based model isn't just about balancing the books, it's a social tool. Because it's funded through progressive taxation, where higher earners contribute more, it's deliberately designed to move resources from the wealthy to the poor and from those who are healthy to those who are sick. It's redistribution in action. Okay, so once all that tax revenue has been collected centrally, the next big puzzle is how to slice up the pie and distribute it effectively across the entire country. This gives you a bird's-eye view of how the money flows. First, the UK Parliament votes on the total national budget. Then, the Treasury gives a specific chunk of that to England for health, and it provides what are called block grants to Scotland, Wales, and Northern Ireland. They then use that block grant to fund all of their public services, including health. So how do they figure out the size of those block grants? Well, it's largely determined by this thing called the Barnett formula. It's a long-standing and, frankly, sometimes pretty controversial formula that basically adjusts funding for the devolved nations based on changes in public service spending in England. Now we get to the really fascinating part. Once the funding is allocated, each of the four nations takes that money and organizes its health system in its own unique way. This is where you really start to see those four separate systems in action. This table just lays out those differences so clearly. I mean, look at the local level. England uses what are now called integrated care systems, while Scotland and Wales use health boards. But maybe the biggest difference is social care. In Scotland and Northern Ireland, it's fully integrated into the health system. In England and Wales, it's a largely separate. Think about what that means for an older person needing care at home after a hospital stay. In Scotland, that's managed by one seamless team. That's a huge structural difference. This slide really gets to the heart of the philosophical divide. For decades, England's approach was all about creating an internal market. You had a split between the purchasers of care and the providers, like hospitals, with the idea that competition would drive up standards. Well, Scotland and Wales looked at that model and went in the complete opposite direction. They dismantled any idea of an internal market and instead built their systems around collaboration, with health boards responsible for both planning and delivering care. Two very different philosophies at play. So we've got the funding, we've got these complex structures, But the real question is, how well does the system actually do its main job, protecting people's health?
One of its biggest, most undeniable successes is protecting people from the devastating financial cost of getting sick. It basically shields you from bankruptcy because of a health problem.
And this chart just says it all. The UK has one of the absolute lowest rates of what's called catastrophic health spending in the world. That's a technical term for when healthcare costs are so high, they literally push a family into poverty. And that low rate is a direct result of that tax-funded, free at the point of use model we've been talking about. But, and this is a really big but, that protection isn't absolute. The system is not totally comprehensive, and some of these gaps cause real problems. Social care is probably the biggest one. It's means tested, which means people can face catastrophic costs. Then you have dentistry, most eye care, and prescription charges in England, where patients often have to pay significant amounts out of their own pocket. And all of this leaves us with the massive, defining question that policymakers, doctors, and all of us are facing today. In a world of rising costs and an aging population, can a system born in the 1940s stick to its founding